Hello, ladies and gentlemen. How are you? This is Dr. Carlo Raj, and I'd like to welcome you to Teapot Clinic, which I'm going to show to you in a second. And also, in the works of Indus Intellect Institute, which is going to be more or less a virtual school or a virtual medical school to begin with. And so, with that said, uh, I've been conducting these private meetings or webinars in which people have graced their presence, and I am extremely thankful. But more importantly, I want to make sure that you understand what the objective is moving forward into 2021. The conclusion of 2020 for many of us probably cannot get here soon enough. So what I wish to share with you, all right, so I am recording, I should be coming in live, is the following. All right. Today's topic is indeed intra-amniotic infection, but let me give you the global perspective as to, as I said, what we're trying to accomplish. And nowadays, it's all about collaboration. And I've been blessed with working with amazing people over the years. These individuals include Dr. Mary Rubish, include Dr. Philip Tisdale, includes Dr. Jack Wilson. I've also worked with an entity called Lecturio. And now at this point, we're bringing everything together in which we have different pieces that we can put together, kind of like a recipe for a fantastic gourmet dish so that you can savor with your medical education. And so with that said, I want to make sure that I give the proper recognition to people that I am working with. This is a medical school companion. You should, I highly recommend it. As I said, the people that are on board who have their own textbooks and such, and we're ready to, well, we have been for the past year and a half, definitely the past 18 months, and have been visiting your schools and delivering the most effective and the most beneficial, relevant information. Dr. Philip Tisdale, pathology. Dr. Jack Wilson, sweetheart, Southern gentleman from Tennessee, for neuroscience. No one does it better. And of course, the acclaimed Dr. Mary Rubish, who does microbiology like no one's business. She's got those bugs down. And of course, immunology and some genetics. So this is a medical school companion. Now, the other project that I have been involved with quite intimately and continue to develop is Bacterial. And this is all over the place. And the objective of this is to make sure that the entire world has access to medical education so that we're on the same playing field. And so therefore you do not have discrepancy between, let's say, United States or Canada versus, let's say, some other country where maybe perhaps access might be limited or restricted. It's a fantastic project. Has been going on for, well, I've been involved since 2013 now. 14 maybe. Whatever. Point being, it's been half a decade. Now, with that said, there are a number of options, and you can go through what you want. They have something called Book Matcher, which basically means that you can take any book or resource that you want. Remember, my goal is to democratize medical education. What does that mean? To make it accessible to everyone who has a thirst for knowledge. Right? That's the most important thing. As long as you have that thirst, then no doubt there are resources out there in which you can then quench that thirst and you come out of it as being an excellent, excellent physician. Now, here with Lecturio, what I wish to show you is that the question bank, Fantastic question. Over 2,000 USMLE type of questions, and then also about 17,000. Yes, you heard it right. 17,000 recall questions as you go through the material. And these are experts that we have all converging in Germany, in which from, let's say, Yale and Harvard and Arizona and Stanford and myself and England and just everything that you need to know about medicine in one spot that is being broadcasted. Today's topic is, yes, intra-amniotic infection, but more importantly, it's the fact that we're looking at pregnancy. So what we're going to get into the habit of doing, as you should see moving forward, and this particular exercise will last approximately 45 minutes to an hour. So what am I referring to? Okay, well, let me do a new share. Okay. So this is Lecturio. Once again, let me show you medical school companion. And these are the three individuals primarily involved with being part of the curriculum. Dr. Dr. Philip Tisdall, Dr. Jack Wilson, and then Dr. Mary Rubish. I'm still trying to figure out the logistics with maneuvering of the Zoom. But anyhow, a point being is this has just been a fun project and one in which we're going to come to and have been coming to your school. And let me show you now the parts of Lecturio that we're going to be using for our particular exercise. I want to show you the USMLE type of questions. And I'm just going to give you a little brief encounter. It's exactly what you can expect when you actually then go into your Prometric Center to take the USMLE. Let's begin our discussion here. All right. You have a 28-year-old woman at 30 weeks gestation, rushed to the ER with sudden onset of vaginal bleeding, accompanied by intense abdominal, pelvic pain, and uterine contractions. That's important. Stop there for a second. So what you should be getting into the habit of doing, if not already, is not only go through the content, but then also dissect the questions as if the patient is walking into a clinic. Now, TPOT stands for the physician of tomorrow. And then in the clinic, I have, at this point, about 100 some patients. And point being is I'll probably come to you once a week sporadically. And even if I did, that's only 52 patients per year. So, I mean, that's a lot of time. That's a lot of information. So am I worried about this information ever being lost? Are you kidding me? There's infinite knowledge in medicine. In fact, the more that you learn, you realize that, or the more that you try to master, the more that you realize you have to learn. So I'm not even worried about this information being disseminated. In fact, that's exactly what I wanted to do. So we are going to work with that pregnant lady today, but as we move forward, I'm going to walk you through opioid addiction. I'm going to walk you through COPD. Obviously, I'm going to superimpose some COVID if necessary. The world still is going to continue with or without COVID. No doubt. COVID has made our life much more complicated. Yes, without question. But what about everything else that occurs with the medical world? So you can't just be a doctor of COVID. You got to be a doctor of, well, the first line, right? Continue discussion. So this patient has abdominal pelvic pain. A 28-year-old lady, young lady, 30 weeks of gestation. And the intensity and frequency of pain has increased in the past 2 hours. There's vaginal bleeding and there's pelvic pain. Keep that in mind. This is her first pregnancy, and she was diagnosed with gestational diabetes mellitus, or diabetes, several weeks ago. That's important, right? Gestational diabetes, and she's pregnant. There's every possibility that there's going to be increased glucose delivery to the fetus, right? And therefore, that fetus is then going to start synthesizing insulin, in which now the fetus then becomes larger and larger and larger. Ultimately, me, with my chubby cheeks, still after 45 years, trying to get rid of my macrosomic features. Macrosomic. That's a possibility. What about polyhydramnios? Sure. Polyhydramnios associated with gestational diabetes, isn't it? That's important. Keep that in mind. Everything's connected. That's the thing that you want to keep out of this. Can't just compartmentalize. Vital signs include a blood pressure of 124/68. Nothing really remarkable here, right? The vitals. Physical exam reveals a firm, tender uterus. Cardiotocographic evaluation shows a fetal heart rate of 150 with prolonged repetitive decelerations and high frequency, low amplitude uterine contractions. So we have uterine contractions, we have abdominal pelvic pain, and we have vaginal bleeding. The attending physician asks you to delay the vaginal exam until a sonographic evaluation is completed. That's important because you might then get a question in which you are then conducting a clinical exam on step 1, in which there is a gestational issue. And you're never going to do what? You're never going to perform a pelvic exam. Why would you do digital examination when you know that there's issues with gestation, trophoblastic issues maybe? Maybe placenta previa, maybe some vasa previa, maybe some placenta abruptio, whatever it may be, placenta accreta. And you start doing digital examinations. And then today's topic, keep that in mind. If you repeat digital examination, you are invading. You are invading that region in which you may then facilitate the rupture of the membranes. And you don't want that. You don't want that. I'll tell you why. Because that'll be our today's topic. Intra-amniotic infection, but remember, everything's connected. Could there be concomitant things taking place? Sure. Let's continue our discussion. Now, the attending physician asks you to delay the vaginal. We talked about that, and which of the following is the most likely diagnosis at this point. So far, what have we looked at? A young lady, first pregnancy. There is abdominal pelvic pain. There is vaginal bleeding taking place. There's uterine contractions taking place. All of that is present, right? And as far as vitals are concerned, unremarkable. Is the patient, what about the history of the patient? Young, right? Was there smoking? Was there drugs? Was there trauma? Here are my differentials. Miscarriage. Oh, if there's a miscarriage taking place while you're thinking about vaginal bleeding, you're thinking about extreme pain and such. But the vitals seem pretty okay. What about vasa previa? Well, we'll talk about that today. Previa. What's previa mean to you? If you take previa and you break it up, and I'm obsessed with medicine, so therefore, the more that I look at words, the more that it speaks to me when you go back to the making and the history of the words. Pre means before. Via means passage. What's the passage in which the fetus is then coming out? That passage is then called the cervical canal, correct? Right? Cervical canal. So you should know that anything that's causing obstruction of the cervical canal, picture that, cervical canal. And as you move proximally, you then enter the uterus. Whole new world, that cavity, uterine cavity. So what I'm trying to say is that an obstruction taking place by the passage via, previa, via, passage before it could be either of two types of previas. You could have the umbilical cord. You would call that vasa. Vasa means vasculature. What's the vasculature in a fetus? Oh, the umbilicus. Right. So the umbilicus is then going to pass over the passage. You wouldn't call that placenta previa for Pete's sakes. You'd call that vasa previa. And we will get into further discussion and content later on because you can have different types of vasa previa. And the more common of the two is then known as your velamentous type of vasa previa. But if that's the case, you'd be compressing the head, the rump, not the stump, but the rump would be compressing the vasa, the umbilical cord, over the cervical canal. The fetal heart rate would decrease. In our patient, in our fetus, we found it to be 150. Having fun yet? Understand the material, apply it to your questions, take your time with the questions, learn from the questions, think of the questions as being your patient, integrate everything that you've ever known about medicine, anatomy, physio, biochem, pathoform, micro, immuno, whatever, and then you'll get your answer. I know it's a lot of information, but you have basically what, a year and a half, 18 months of getting all that information so you can get in. No excuse not to do well. Uterine rupture. Oh, goodness gracious. The pain there would be excruciating. It'd be an absolute emergency. You wouldn't have all this time here to wait around for a sonograph and such, right? No way. And we have placenta previa. What's that mean? Oh, the previa is there as well. So now it's causing obstruction of the cervical canal. Not the umbilical cord, but the placenta. Remember, the placenta should normally get implanted by the body and fundus, right, of the uterus. Picture that. Close your eyes. Picture that. Are you in the beautiful womb of your mama? Beautiful place to be. It was so safe back then. It wasn't all this chaos, uncertainty, unpredictability. Anyhow, life. But in the body and fundus is where usually implantation takes place. What happened? The placenta, maybe due to previous cesarean, the uterus then got loosened up. And what happened is that the placenta then dropped lower down over the cervical canal. It dropped down over the cervical canal. So what does that mean? It may then cause obstruction. Would it cause abdominal pelvic pain? Not so sure about that. Would it cause vaginal bleeding? Oh, yes. In fact, all of these cause vaginal bleeding. Miscarriage, VASA, uterine rupture, placenta previa. But our patient had abdominal pelvic pain. Placenta previa will not present as such. Is that clear? There will not be abdominal pelvic pain. It has to be that black and white on your step, or you're never going to get a question right. You know what I mean? So maybe you've narrowed it down to answers of D as in David, E as in epsilon. Placenta abruptio. Wow, this is a young lady, maybe anxious, maybe there was a history, even though it may not say that here, of maybe drug abuse, maybe there was accident, maybe there was hypertension, stress, what have you. And there was vaginal bleeding, yes. And there was pelvic pain, correct. There was uterine contraction, yes. And the fetal heart rate was increased, yes. Of all the answer choices, you should be liking placenta abruptio. Now, is it possible that you may have placenta abruptio without the vaginal bleeding? Sure. But on your boards, most likely they are going to give you vaginal bleeding because you do have complete and partial abrupt separation of the placenta from the residual, the endometrium of the mama. And when that happens, with partial, you'll have bleeding taking place. So you can see here, a simple question, a little discussion, just so that we have a little bit of an intro. And you should be doing question banks. Highly recommend Lecturio, no doubt, because you have the content. You also have something called, where to go? You also have something called book matching, wherever it is. Yeah, yeah, book matching. I lost it. But the book matching means that you are then matching any book that you want to take. Let it be Medical School Companion, let it be TPOT, let it be Cecil's, let it be Ferries, let it be Harrison, let it be Bates, let it be Pathoma, let it be, I don't care what it is. Whatever it may be. You would then take the page and the information, and then you would scan it with the app that you have on your phone over the material, and then it would then take you to the relevant content of the video of Lecturio. Amazing. Nothing that you can't do with technology if you use it for the right purpose. If. Okay. Let's now move into further discussion here. And our topic of intra-amniotic-infection, which I think is to be amazing. All right, so welcome to TPOT Clinic. And I've shown you a little bit here and there, but as I said, the point being of all of this is gone are the individual subjects moving forward. We're going to put you, the medical student, first, second, third, fourth year, maybe even residents, into the clinic. And we're going to do grand rounds in the clinic. We're going to do CPCs, clinical pathologic correlations. We're going to sit around and go back to the days in which Socrates would sit around with his clan of extremely thirsty, curious medical students and doctors. Actually, we're medical students forever, and had discussions about the patient. But now we can do it now, here. Amazing. All right, now, with that said, Look at our lady. We'll call her June. Hi, June. How are you? She says, Doc, I'm doing okay. I just want to make sure that everything's kosher with the pregnancy. So she's pregnant, right? And I'm going to show you some stuff that would then tell you what may then be happening here with June. The entire world is changing. It's what you make of it. I say that because I wish I had these type of resources when I was just going through school period, you know? All right. Intra-amniotic infection. So we have to take a look at some relevant anatomy because those will be questions that you'll get. All right. We will also be looking at some embryology. Those are some questions that we'll get. We'll go through some physiology. So in other words, we'll be going through our patient. IAI, intra-amniotic. Close your eyes for a second, and I need you to picture the amnion. Right? And the amniotic fluid, for the sake of simplicity, is being churned out by the fetal kidneys. I think of that fetus taking a pee, but it's peeing out amniotic fluid, filling up the amniotic cavity. Keep that separate from the chorion. If that is something that you're having issues with, don't worry. We're going to be focusing upon it. Because another name for intra-amniotic infection is clinical chorioamnionitis. Chorionic cavity. Amniotic cavity. Itis, inflammation. So nowadays we call it triple I. 3 names for this. Intra-amniotic infection, chorioamnionitis, triple I. Why is it triple I? The first I, intra. The second I, intra-amniotic infection. Or it could be inflammation. The third I, intra-I. Infection I. Inflammation I. Triple I. Group them together, clinically, please. When you say acute inflammation, I'm bringing in neutrophils, right? Neutrophils. What if there was infection taking place from the hematogenous route through Staph aureus or Listeria monocytogenes, hematogenous route from the mama, encroaching upon the placenta, the transplacental route, the vertical route? Is that a possibility? Sure. And back to infection, mounting acute inflammatory response in which neutrophils are coming in. These neutrophils are then causing issues with the residual, the placenta. The placenta is then made up of syncytial cytotrophoblast, right? Syncytial cytotrophoblast. Keep that in mind. So what if you then find neutrophil infiltration of the syncytial trophoblast on the side of the chorion? Call that chorioamnionitis. Right. What if more commonly, now the hematogenous route, picture that hematogenous route. So literally the blood from the mother is then feeding an infection to the placenta, chorioamnionitis. Organisms, Listeria, maybe staph, right? But most of your infections, intra-amniotic, will be taking place through the cervical vaginal canal. Yes, the cervical vaginal canal. In fact, there are theories out there where maybe chorioamnionitis or triple I may not even be a separate infection. It might just be migration of a colony that was hanging out by the vagina, right, distally. And then it started migrating through the cervical canal and then hit the fetus. But that's the most common route. That's the most common cause of intra-amniotic infection. Do not forget that. Now, when that occurs, imagine now that the umbilical cord may then get infected of the fetus. You'd find neutrophils. However, the infection of the umbilical cord, you're not going to choose chorioamnionitis. infection of the umbilical cord is called Phenicitis, isn't it? Phenicitis, F-U-N-I-S-I-T-I-S. So you want to keep that separate, but ultimately it's all intra-amniotic infection, isn't it? But you want to keep that separate. So now you have, as I said, the cervical vaginal type of migration, and then you also have a hematogenous. Of the two, what's more common? No doubt, the cervical vaginal. With the cervical vaginal, I'll give you two very important organisms. Mycoplasma hominis, Ureaplasma urolithicum. All right? Mycoplasma hominis and Ureaplasma urolithicum. Now, the ureaplasma seems, well, I'll talk to you about the virulent factors coming up shortly. But of the two, there's virulence that then causes further complications. So now that we have a global understanding, we have to talk a little bit more. All right, so let's move on. Why the heck do I have to know this, Dr. Raj, to begin with? It's common. The incidence is common. Look at this. It's one of the most common causes of peripartum infections in the U.S. Approximately 4% of all women giving birth. When you say giving birth, what does that mean? This lady, when she's about to give birth. Remember that term is approximately 39 weeks. All right? Term is approximately 39 weeks. Yes. Preterm is less than 37 weeks. Know that for your step. Pre-labor is another name for premature. Wow. That's a lot of definitions. Yes. But if it's been some time since you've seen it, then everything kind of runs together. There's a difference between preterm. Preterm would be, by definition, less than 37 weeks. You can have moderate preterm. You can have severe preterm if you start dropping down into 27 weeks and such, in which maybe now the fetus is at risk of developing neonatal respiratory distress syndrome. We're not going there. We're going to focus on 37 weeks right now because you've heard of the acronym PROM. PROM stands for premature rupture of membrane, ROM, rupture of membrane, not range of motion, but rupture of membrane. What's that first P? Premature. What's another name for premature clinically? Is it preterm or pre-labor? Preterm is less than 37 weeks. Yes. Pre-labor is what every lady looks forward to as she is about to deliver at term. So pre-labor. And then remember that with delivery, there'll be stages, right? There'll be stages. 3 stages. In the first stage is what you're going to focus upon. And we have the early phase. So in the stage, we have early phase. The early phase there could then be pre-labor. Why am I bringing all this up with PROM? Because if you did then have premature rupture of membrane, in other words, your water broke, that will never happen to me, unfortunately. As much as I would love to have my water breaking, it ain't going to happen. God just didn't make me that way. Point being is, if my water did break, I then had rupture of my membrane. If my rupture of the membrane took place during pre-labor, in other words, premature, that means that the barrier, remember, what's the most common route of infection for intra-amniotic infection? Cervical vaginal migration, right? Cervical vaginal migration. So if there's rupture taking place of the membrane early enough and long enough, I have now made it accessible for these infections, for the cervical vaginal to make its way to the fetus. Not good. Keep that in mind. Now that you have a good picture of what's occurring here, because it's common. We talked about some complications earlier. I did a question with you with placenta abruptio, but any one of those really trophoblastic or gestational type of diseases in which you may then have rupture of the membrane put you at risk of developing intra-amniotic infection. Now look at this. So we said 4% of all women giving birth. Then we have preterm. What's preterm mean? Preterm means not premature. Preterm means less than 37 weeks. So if there was rupture of the membrane taking place preterm, 40 to 70% of your patients, pregnant women, would then develop intra-amniotic infection, triple I. Sounds like a movie, triple I. Triple X, you've heard of before? With, what's his face? Vin Diesel. And then the Later version with Ice Cube. Less than 37 weeks. And we have PPROM. And it puts everything together here. Preterm, less than 37 weeks. Pre-labor, another way of saying premature. ROM stands for rupture of membrane. And if that is to occur, goodness gracious, this young lady and that fetus within is at risk of developing triple I. At term, more of this incidence here, 1 to 4% of all deliveries. You can now understand. I get it, Dr. Welch. It is quite common. Yes. It is important that you know the details. Now, how is all this working? What kind of questions are they going to get? What about the anatomy and the embryo? Well, now we're going to do more integration. We're going to shift over from incidence to make sure that you're well versed with the chorion, the amnion, the placenta, that you're well versed with the egg and fertilization. And along the way, I'm going to make sure that you're good with the different type of births. In other words, were there twins? What does it mean by twins? What does it mean by the number of, let's say, chromosomes and the chromatids and the blastocysts and the morula, 2-cell stage? Can we do that? Let's. Is it important? All of it is. That might be a little difficult to see, so let's get a little bit closer, shall we? Oh, yes. Let's set this up. We're playing Monopoly. You start here in the ovary, and you finish here, right? Start and finish. Let's play. These options are absolutely fantastic. We're going to draw. We're going to attempt to draw, believe it or not. Let's see what happens. Okay, so there's my start, and there's my finish. I'm going to walk you through some important physio. This will be fun. Maybe, just maybe, I'll inspire you to go back and read some reproductive physiology this evening on a Sunday. Beautiful reading. It's all nature. It's not us. It's a force beyond us. This whole thing is the ovary, right? And I need to make sure that this is a follicle, right? This follicle right here. Everyone knows about my wonderful handwriting. And within that follicle should have been an egg. Should have been an egg. Ladies, of course, know this. Your wonderful menstrual period in your reproductive lifespan. You're going to go right smack dab in the middle of your menstrual cycle. Bam! Right in the middle, right there. What's going to happen in that middle? Are you going to bleed in the middle of your menstrual cycle? I hope to God that you do not. But what you will do is be releasing this egg. Bye-bye egg. From the ovary through the peritoneum. Think of the peritoneum as being space. Like a satellite with Elon Musk's SpaceX launching his satellites so that he can bring you internet and he can bring us to Mars. That's the egg being launched from the Earth, going out into space, the peritoneum. And in that very moment when that occurs, every month, right smack in the middle with ovulation, ow! That hurts a little bit because a little bit of blood is then causing irritation to the peritoneum. That's called Mittelschmerz in German. Mittelschmerz. Right smack in the middle. Right. What's causing that ovulation? What's the hormones that you must know? In order. There are two of them. So you go to a CVS, you go to Walgreens. In fact, a lot of things that you want to know about pharmacology for step 1, step 2 in practice, just have a nice little date up and down the aisles of Walgreens or CVS or whatever pharmacy that's your fancy. And you pick up a conception kit. A conception kit, not a pregnancy kit, a conception kit. You want to become pregnant. You want to confirm pregnancy, you check for HCG, no doubt. You want to check for, confirm that your pregnancy at home, that's your home pregnancy kit, that's your HCG. That's if you became pregnant. But you wish to then become pregnant. A conception kit is different. On the back of the box, 2 hormones. It says 2 hormones, still layman, but you as a doctor know that it is, number 1 in order, high-dose estrogen. High-dose estrogen has a positive feedback on the anti-pituitary. It's then going to release luteinizing hormone, the 2 hormones that are necessary for ovulation, so that the egg then gets spurted out into the fimbriae, right? Into the fimbriae. Conception kit. In other words, once that litmus paper with the face goes beep, solid beep, she is now ready for conception, right? And you have approximately 36 hours after ovulation in which you may then fertilize the egg. Don't forget that. She's not pregnant yet, but you, the couple, needs to know when to conceive. High-dose estrogen, LH. They work in cahoot. All right, there it comes. And in the meantime, I have the tadpoles, these critters called sperm. La-di-da-di-da. I mean, millions of them, right? Millions of them. It's almost like real life. Millions of these guys going after this one egg. Maybe just one will be lucky enough to then penetrate the zona pellucida of the egg, so fertilization will take place. Do you ever think that you'd be discussing intra-amniotic infection, but yet you have all of this? Here we are. Welcome to medical education. Fascinating. So we have LH shooting out the egg, and we have sperm, zona pellucida, and we have fertilization taking place. But right before that, at day zero, I have 2N, 2C. What's that mean? N is the number of chromosomes. C is chromatid. In other words, the DNA. So N, the first N is chromosome. The C stands for chromatid. In other words, the copies of the DNA. Do not confuse that. So this right here refers to the DNA. And this here refers to the chromosomes. This is at day zero. What's going to happen? Fertilization occurs. Right. So what's going to change? Not to 2N, but to 2C, right? So you're going to move from 2N and 2C to 2N and 4C. What's C refer to? Not chromosome. It refers to DNA because it refers to chromatid. Continue our discussion further. And now I formed a zygote. And that zygote has 2N, 4C. Let's have a little bit of fun. What do you mean fun? You're expecting one child. Goodness gracious, you got the news that during this prenatal visit, it's been confirmed that instead of one for the person, what do you get two? You get 2 lovely babies. Merry Christmas, happy birthday, whatever. So the point being is you have 2 babies that are coming. 2 babies, but we'll discuss. Most of the time when you have twins that are coming, they're going to be of the fraternal type, all right? 2/3. So approximately 66% of the time, you're going to have fraternal. What's fraternal mean? It means you have 2 of everything from the get-go. Not just does one zygote get fertilized, but 2 zygotes get fertilized. When 2 zygotes then get fertilized, they then go through the 2-cell stage, 4-cell stage, morula stage, blastocyst stage, implantation. 2 of everything. 2 of everything. So there's no splitting of the egg. Is that clear? That has to be understood. That occurs majority of the time with twinning. That's fraternal. And that is then referred to as being a dichorionic, diamniotic, dizygotic twin. Dizygotic. So you're going to have 2 chorions, 2 amnions. That's easy. But don't forget that that's most common in terms of twinning. Right. Now, things get a little bit more complicated because those 2 zygotes are never going to come together and form conjoined twins. That makes no sense. They're 2 separate, independent life forms. in that beautiful uterus, trying to then just live its life. Two of them. Dizygotic, dichorionic, diamniotic. Life. Right there. Amazing. Next. We're going to take one zygote, 2N4C. We'll take it at the 2-cell stage. So now we have monozygotic twins. Not dizygotic, monozygotic, and monozygotic twins are only 1/3 of the time. Monozygotic are only 1/3 of the time. But the monozygotic is the one that you have all these different variations that I'm going to walk you through. What if at the 2-cell stage, right here, the 2-cell stage, that there's cleavage taking place? Well, if there's cleavage taking place at the 2-cell, it's almost like having two separate entities. So it's monozygotic, one zygote, but at the 2-cell stage, you then have cleavage taking place. So cleavage taking place at the 2-cell stage is then going to give rise to dichorionic, diamniotic, dichorionic, diamniotic. But it's monozygotic twins. Is that common? Maybe 25% of the monozygotic type of twins. 25% of the monozygotic twins. How common is monozygotic? 1/3, 33% of the time of your twinning. The most common, dizygotic, which is 2/3 or 66%. Let's continue discussion further, shall we? So the monozygotic 2 cells is then going to give you dichorionic. So keep that separate. I'm going to put dichorionic, and diamniotic. So there is a difference between the chorion and the amnion, isn't it? That's important. Now let's say that you get into, oh goodness gracious, let's say approximately, we have 4-cell stage here, and then we get into our marula. Marula, right there. All right, so you're getting closer into the uterine cavity, hopefully trying to implant, but not implant down here, huh? That's called the previa, isn't it? Pre meaning before, via means a passage. Implantation of the placenta should never take place there, nor the umbilical cord, right? Now in the marula, if you start having cleavage taking place there, take the M in marula, and if you have cleavage taking place, the type of twinning that you're going to have is then called the mono or monochorionic. Diamniotic. And that is the most common type of monozygotic type of twinning, monozygotic. So far we have two variants of the monozygotic. You have the dichorionic and the diamniotic. That was cleavage of the 2-cell stage. If it's a marula, then you're going to have a monochorionic, but then you're going to have a diamniotic. It's still going to be a monozygotic type of twin, but a separate type of variant. Now, anything beyond that, beyond the marula, you start getting into your, let's say, 8 to 12 days beyond the marula. So the marula is approximately, let's say, 4 to 8 days. And then you start getting into 8 to 12 days. If it's 8 to 12 days, then it's going to be not just monochorionic, but then also monoamniotic. Beyond 8 to 12 days. Now, when you say monochorionic, monoamniotic, not only are they then sharing one chorion, but they're also then sharing one amniotic sac. Which, at what point would you then say the twins are conjoined? Literally, body to body, right? Conjoined. On step 1, the disc. When the embryonal disc, by definition, when the embryonal disc has been formed and the cleavage takes place of the disc, you're going to have a monochorionic, monoamniotic type of monozygotic twin. In addition, they're going to be conjoined. And that, ladies and gentlemen, is rare. Right before the disc formation, beyond 8 to 12 days, you could also then have a monochorionic, monoamniotic, but they're not going to be conjoined. Wow. So you have 4 variants of the monozygotic, but the monozygotic is only 1/3. But that's where you're going to focus your studying on with the monozygotic. Fascinating, isn't it? So you can have your dichorionic, diamniotic. You can have your monochorionic, diamniotic, or you can have a monochorionic, monoamniotic, 2 types. The conjoined would be after the disc formation. You can't separate the bodies. Cannot separate the bodies. Let's go down further now. Implantation taking place. You're going to have participation of the mother along with the fetus, right? So from the maternal side, you're going to have your syncytio and the cytotrophoblast, which is then going to form your placenta, ultimately. And in the meantime, what's occurring is that the fetus needs to be fed. How is the fetus going to be fed? We're going to predict it, and then I'm going to go into further detail. The detail is the fetus is going to have chorionic villi. The chorionic villi is then going to penetrate into the deciduum. Villi means what? Finger-like projections. We have villi all over the place, don't we? For example, the duodenum, think about that. We have villi there, increase the surface area. To do what? Absorb the nutrients, correct? Same concept. Here, the chorionic villi that the fetus is going to express, diving and penetrating into the mother so that the fetus can extract the nutrients from the blood that the mama is then providing. I'm going to show you a picture of that. So the blood is going to be in this intervillous space that I'm going to show you. The blood is. That blood is full of oxygen, full of nutrients, full of electrolytes, full of glucose. And the chorionic villi is going to penetrate, and within each villi, you're going to have fetal capillaries. Fetal capillaries. Beautiful. The fetal capillaries are reaching for the oxygen, the glucose, electrolytes, and nutrients. And then it's going to pick it up. It's going to travel through one umbilical vein. One umbilical vein. That's interesting. So Dr. Rogers saying that I have a vein here which is carrying oxygen. That's correct. A huge exception for the rule, isn't it? Veins usually carry deoxygenated. Everyone knows that, doctor and non-doctor. However, the umbilical vein, one of it, responsible for transporting the oxygen that was extracted from the maternal blood to the fetus through the umbilical cord. Hopefully nowhere near the cervical os. Let's take a look at that. And here we go. Not as clear as I would like. Let's see if I can blow this up a little bit. Come on. Excuse me, June. Sorry about that, June. All right, that's good enough. I don't need the annotation because I know it, as you should as well. Let's begin. I wish I could blow it up just a little bit. I'm sure there's a way, but I can't find it. Let's see, because it's a little bit difficult to see, isn't it, to be honest? Let's parade through the closer. Okay, that'll work. That'll work. Perfect, actually. Okay, a little blurry, but when you get the text, it'll be clear for you. And let's begin our discussion. Here's the uterus. Draw. So we're going to call this the side of the mother. Okay. And here's the side of the fetus, obviously. Here's the umbilical cord coming out. And I'm sorry that the picture is not picture perfect, but when you come into the clinic, all this information is given to you. Trust me, on the PDFs, it is crystal clear. But you can follow. What's the point of all this? The point of this is to then show you what are the fetal structures that are then responsible for extracting the nutrients from the mother, and the blood that I'm going to give you from the mother that will provide those type of nutrients. So we're going to take this entire section, mother on this side with the residual and the endometrium. On the side is the fetus. And what I wish to show you, you see all these, the pool of pink or dark pink, almost like magenta. The pool that you see there of pink and magenta and such is the area of the chorionic villi from the fetus penetrating into the decidua, extracting the blood from the mother in the intervillous space. We're going to take that entire structure and then blow it out for you here. So let's take a look. Here comes the umbilical cord. What does that umbilical cord contain? Well, we want to extract oxygen from the mother. So as you're moving from the fetus, and blow it up, let's blow this up here, and then we're moving into, see this now? Into the chorionic villi. So the villi are then penetrating into the decidua. Each villi, which is this potential space, then contains the fetal capillaries. That's what you're seeing here, the fetal capillaries. These are fetal capillaries. So therefore, the two umbilical arteries coming out from the fetus, out. Remember, it's an exception here in the fetus. The arteries are deoxygenated, the veins are oxygenated. So the arteries which are then oxygenated, or the veins which are oxygenated, it became as such because the arteries were making its way out, and then just normal anatomy becoming capillaries. In the meantime, what ends up occurring is that the mother, through her endometrial artery and veins, she is dumping blood into the intervillous space. So I'm going to color all this here. And this red that I'm coloring in represents maternal blood. Just pouring it into the intervillous space. So in between the villi, you have space. That space is then being completely filled up with, so think of it as being a bucket, a container, or a car that's empty on gas. That tank is then being filled up with the gas. The intervillous spaces are then being filled up with the maternal blood, which then contains the oxygen that the fetus requires. In the meantime, what is that fetus doing, please? In the meantime, the fetus has then extended the chorionic villi, not the amniotic. No such thing. The amniotic would be over here. So it's kind of like the fetus being in a bathtub or a hot tub. Really comfortable, really warm, allows for protection. There's cushion when maybe the mother might be moving around a little bit, shifting a little bit. So it's that buffering ability of the amnion that keeps that beautiful life form stationary and safe. Amazing. And that's the amniotic cavity. The amniotic cavity is filled with nutrients. It is. But the method by which the nutrients got to the fetus was through the help of the chorionic villi. So the chorionic villi extending out with the fetal capillaries, extracting oxygen from the maternal blood. So all this being poured out by the endometrial artery. endometrial. Remember, in an adult, our arteries, right, for the most part, so endometrial is the mother, contain oxygen. So the endometrial artery is then dumping blood into the intervillous space, and the fetus is doing what? Well, the fetus is then extracting it from the capillaries and then coalescing into one umbilical vein, filled with oxygen, traveling through the umbilical cord, and then to the fetus. And of course, that takes you into the fetal anatomy, in which you've heard of the shunts from the liver, for example, sinus venosus, and you go into the heart. And of course, you then have your foramen ovale. And then, of course, you're going to completely avoid the lungs as you then make it into the pulmonary artery. And then you're going to go through the ductus arteriosus. Are you picturing all that? Good. So that's how all that occurs. And that's why you want to keep this separate. Now, take a look at the rump here, the head. And that's important for us because our topic of intra-amniotic infection, now that you have hopefully a decent idea of what's going on here, the fundamentals, and if not, well, you have time to study. Now, if you take a look at the rump here, the head, and there is the cervical canal. And I told you earlier that the most common entry point of these infections are going to be through the cervical vaginal canal, coming up this way. The organisms here are then going to be things like ureaplasma urolyticum, Mycoplasma hominis as being the two most common culprits. If it is indeed going to be hematogenous, then it'll be in that direction from the mother, and that'll be things like Listeria monocytogenes. But that is rare, hematogenous route. And this is what you're going to focus upon. Now, usually the membranes, the fetal membranes, and the mucus itself, the mucus plug, all this protects and creates a barrier so that the bacteria cannot make it through. It gets deflected, or very little of it ever gets through. If it does get through, and then it does cause infection to the fetus, and then it causes infection of the umbilical cord, then you would then call it Phenicitis. Phenicitis has 100% association with chorioamnionitis, but not the other way around. So it's possible that you may have infection of the umbilical cord. What are you going to find? Neutrophilic infiltration. You could then have infiltration of the chorion of neutrophils, and because of the adjacent nature of the chorion, along with the amnion, the amnion is always going to be the innermost layer. The chorion is always going to be the outermost layer. It has to be, because how else would you then form the villi, right? Down here, proximally. So the villi, which is then made up of your chorionic layer. So try to make sense of it. And that is going to be a chorioamnionitis. Hopefully that helps you out. Now, earlier we did a question. And that question, USMLE related or medically related period, was the fact that our young lady, let's say, for example, June, had a vaginal pain or abdominal pelvic pain. She had vaginal bleeding. Oh, goodness gracious, what was that? Oh, there we go. Had vaginal bleeding. And let's say that she had uterine contractions. And if that was the case, then remember that our issue with that young lady was indeed placenta abruptio. What if there wasn't abdominal pelvic pain and it was just painless vaginal bleeding? Painless vaginal bleeding. Then at that point, you're thinking about placenta previa. Okay, we're just about wrapping things up here. So that you give an idea. You can see that we never just keep it to one subject, do we? Impossible. And nor should you. As you get through this, put in the relevant embryo, put in the relevant anatomy, put in the relevant physio, and so forth. And there's so much that I could talk to you about, but try to keep it simple at this point. And I really am keeping it simple. All right. Just want to finish this up here because it's been quite a bit of information. These are then known as your cotyledons. And if you take a look at this upon closer inspection, this is the side of the mama. Get a little bit closer. There we go. This is the side of the mother when you then remove the placenta. And what you're looking at here are then going to be your cotyledons. And within that cotyledon, you can then imagine that you would then have your chorionic villi. You would have your umbilical blood vessels, and then trying to extract the blood from the mother. This is aside from the fetus. And there's the umbilical cord going to the fetus. Remember, it contains one umbilical vein, which is oxygenated. It picked up the oxygen from the mother in the intervillous space, which was then being provided by the endometrial artery of the mama. What is amniotic fluid? This is what is referred to as being your water breaking. And so therefore, if you come to term at approximately, let's say 38, 39 weeks, and then pre-labor, which lasts approximately early phase, let's say about 8 to 12 hours on average. Could be less, it could be more, but it is that rupture of the membrane taking place, ROM. And it could be PROM, in other words, premature, pre-labor rupture of membrane. And it is at that point in which the fetus may then be susceptible to intra-amniotic infection, but hopefully the fetus comes out of it unscathed. That's what you refer to as being your water breaking. It should be odorless. That's important because if you then test for the amniotic fluid, and that's important because you want to try to avoid invasive testing with the amniotic fluid. You want to try to do gram staining. It's quick, not as reliable, but it's not as invasive as then checking for the amniotic fluid. But normally it should be odorless. And as soon as you smell something of the amniotic fluid on your steps, you know you're thinking about infection. Made up of maternal plasma, fetal urine, as I said. The composition continues. Less than 12 weeks, water and electrolytes. Greater than 12 weeks, you start getting into proteins and more of the good stuff. What are the risk factors for intra-amniotic infection? Longer the duration of the labor, the more that there is exposure of the fetus to infection. Simple as that. Therefore, PPROM, all right, so preterm, pre-labor, perhaps. Prolonged labor, and during that time, there might be multiple digital examinations. The repeated multiple digital examinations may then facilitate the migration of the bacteria from the cervical vaginal canal to the fetus. Usually go hand in hand. What are the infections? Well, if it's a cervical vaginal route, then you're thinking about your polymicrobial, more common. Ureaplasma referred to, Mycoplasma hominis are referred to, just about any gram-negative anaerobe migrating from maybe the normal flora or the flora of the cervix and the vagina. Urinary tract infection, bacterial vaginosis. If it's hematogenous spread, picture that from the mother. Rare, but then it could be Listeria monocytogenes or staph. And if that's the case, these tend to be monobacterial, not polymicrobial, usually monobacterial. And the complications are usually worse if it's hematogenous. Or if the meconium is stained, look for that. Or vaginal prostaglandins, you start thinking about PGE2, PGF2 alpha, epidural anesthesia, all risk factors. Clinical findings. All right, now, what are we looking at? This mother with amnionitis, she, without a doubt, is going to be presenting with fever. 100%. You have to look for that. Her heart rate is going to be above 100. The fetal heart rate is then going to be usually above 160. So you have tachycardia taking place in both the fetus and the mother. The amniotic fluid is going to be foul smelling, either during birth or during testing. She may then have increased WBC count because it's an infection or inflammation. Greater than 15,000. Remember that normal is approximately 4,500 to 11,000 cells per millimeter cubed. WBCs. Bacteremia, every possibility that the bacteria may then enter the blood. Now, histologically, what you might find, here's the amniotic cavity. So that's going to be the side of the fetus. Here is the intervillous space, which is filled up with what? With maternal blood being dumped from the endometrial artery. If you then find neutrophilic infiltration taking place of the amnion, you see here, along with the chorionic vessels, there's every possibility if it then enters the vasculature, you would then call that chorionic vasculitis. If it's causing infection, inflammation of the chorion, then we call this chorioamnionitis. And then if it then migrates to the umbilical cord and there's infection, inflammation of that, then you refer to that as being phenicitis. All basically a spectrum of intra-amniotic infection, triple I, infection and inflammation. Notice neutrophilic inflammation, depending as to what side of the fetus that you're referring to, fetal or maternal. Now you understand how it's occurring, cervical vaginal, or maybe perhaps hematogenous. And more importantly, now you understand the simple terms here of intervillous space. What does amniotic cavity mean to you? What is amniotic fluid? What is the chorionic cavity? What does it do? All things that we just discussed. We also discussed what kind of things may then happen as you go through pregnancy. So maternal response, chorioamnionitis. Fetal response, phenicitis. What does that mean? Umbilical cord infection, inflammation. Chorionic plate, what does that mean? That contains the fetal blood vessels. And so therefore you call that chorionic vasculitis. It's all spectrum. Complications. A cute little picture here for us to learn, but not for the fetus. Phenicitis we've talked about. There could be necrotizing enterocolitis, all due to what? Chorioamnionitis or intra-amniotic infection. The thymus should be rather large to educate the T cells, but there might be then thymic involution. This is not good. Thymic involution will take place, in a child, but in a fetus, it should be nice and hearty and meaty and absolutely functioning. May result in respiratory distress syndrome or bronchopulmonary dysplasia. There might be decrease in, this is not good, of your thyroid hormones called THOP or THOP, transient hypothyroxemia of prematurity. Not only would there be HOP, but there might be ROP. So this kind of reminds you of what? Doesn't this kind of remind you of the issues that may then be taking place with neonatal respiratory distress syndrome when you give oxygen, right? So those of you right now that are on the cusp of studying for, let's say, pulmonology or step one, whatever, the point being is, as you've gone on to discuss NRDS, neonatal respiratory distress syndrome, you have no choice but to give that child oxygen, right? But when you give that oxygen to this infant, there's every possibility that the oxygen may then turn into free radicals. That free radicals may then cause bronchopulmonary dysplasia, may result in necrotizing enterocolitis, may result in retinopathy of prematurity. Well, kind of behaves the same, does intra-amniotic infection. And then not only that, you're also going to look for neurodegenerative diseases, white matter disease, or even cerebral palsy with the germinal matrix. It's a nice little summary that you need to make sure that you're comfortable with. If intra-amniotic infection goes undetected, these are serious sequelae that you cannot take for granted. Now, how common is this? For Pete's sakes, it's 4% of all deliveries, 40-70% of PPROM, in other words, preterm premature rupture of membrane. In other words, it happens all of the time right now in hospitals across America. And if you're not paying attention, this young child is then going to have serious detrimental effects in a permanent nature. Yes, now things are being serious. APGAR score less than 3. Remember, 10 is what is normal. So you have things like appearance, and you have activity, and you have your pulse, and then you have your respiration. Each one of these are designated 2 points each for a total of 10. But if there is intra-amniotic infection, may then result in less than 3. That's not good. I mean, that is severe issues. Neurodevelopmental issues, seizures, cerebral palsy, and infections like we talked about, pneumonia, meningitis, or even sepsis and death. Maternal complications. Her labor might be dysfunctional. Postpartum hemorrhage. In fact, the hemorrhage might be so bad that she will then undergo pituitary infarction. And with that pituitary infarction taking place in the mother, you can then imagine that she's not going to have proper prolactin, so she can't feed the baby. But more importantly, she doesn't have what? She doesn't have the ACTH, so that you could then have the cortisol and glucocorticoids, or even the mineralocorticoids. She's going to be loss of the glucocorticoids, such as cortisol, which is a stress hormone. So those are one of the first hormones that you're going to start replenishing, aren't you? And Sheehan syndrome, with all that hemorrhage taking place. She might be losing so much blood that her anemia is so bad that her hemoglobin will be less than 7. If that's the case, then now she becomes a candidate for what? Blood transfusion. The organisms that are virulent, the Mycoplasma hominis. Where did it come from? Most likely cervical vaginal canal. The low virulent ones, Ureaplasma urolyticum. Okay, so the virulent ones are the ones that you really want to be careful of. Bacteremia, you're always going to follow that lactate. That lactate, please note clinically, is going to tell you the severity of the sepsis. Yes, without a doubt. Do not forget that ever. So if you are taking measures, for example, when you do sepsis, remember you're going to use suppressors. You have sepsis taking place and result in septic shock. So therefore, you're going to have massive vasodilation. The patient feels warm and dry, correct? Warm and dry, lots of vasodilation. You're thinking about giving norepinephrine, aren't you? Point being is, as you manage your sepsis, hopefully you caught the sepsis in time, then the lactate level should start dropping. So that'll tell you the severity. Thromboemboli is a possibility, and I walked you through abrupta placenta. What to try it again? Is she going to have vaginal bleeding? Yes, in fact, I gave you a question with beautiful differentials of vaginal bleeding when we started our little discussion. These included miscarriage, included uterine rupture, included DARA, placenta abrupta, included placenta previa, and vasa previa. Those are the answer choices, weren't they? Our patient, let's say June, ended up having things like what? Uterine contraction, there was fetal tachycardia, and there was what? Painful vaginal bleeding. That's going to be placenta abrupta. Diagnosis. Gold standard, without a doubt, is going to be culture of amniotic fluid, but it's invasive. So be careful. And it does take time for it to come back. So therefore, the rapid results, gram stain. Kind of like Elon Musk right now, who is waiting upon his, let's say, PCR, right? So the nucleic acid amplification test, or NAT. It takes time for it to come back. The amniotic fluid takes time to come back. But the gram stain is going to come back rather quickly. Reliable? Not always. Now, the glucose concentration, remember, this is analogous to bacterial meningitis. Bacterial meningitis, remember, you're going to find what in the cerebrospinal fluid? You're going to find tons of protein, you're going to find decreasing glucose, and you're going to find neutrophils, aren't you? Why the decrease in glucose? Because bacteria is consuming and eating the glucose. Here, with bacterial infection, the glucose concentration that you're then going to find, as you can imagine, is going to be decreased. Less than 14 is the magic term. Very good with sensitivity and specificity when diagnosing intra-amniotic infection. But most relevant will be clinical. Management, delivery, antibiotics, gentamicin, ampicillin. Gentamicin is what? Aminoglycoside, isn't it? Aminoglycoside. Remember, buy at 30 and sell at 50, correct? Remember, what does that mean? When you buy at 30, you're focusing upon the A and T. You buy at low prices, 30S. The A stands for aminoglycoside. Gentamicin will come there. And then you have ampicillin. And this is the IV interpartum. So have to be aggressive in terms of taking care of the bacteria, or otherwise could result in long-term sequelae. And then the resistance that we're seeing is more and more of this biofilm, in which this bacteria firmly adheres to the structures in which it then proves to be resistant to the antimicrobials. Okay, so we're going to end here with management of intra-amniotic infection, but we just went through an entire slew of all kinds of information. We just went through in the clinic here of what you can expect as we go further. Now, remember this young lady here, the discussion that we then have in our full bloom clinic when we start really moving into schools across the world is the fact that we're going to sit down with our students. We're going to pick up topics such as female reproductive. And as we do so, we're going to begin with the embryo and the anatomy. Begin with embryo and anatomy. Make sure that you're solid with that. And if you're not, then make sure that you go back and review. You'll have the material, the content, either in the form of, well, both the PDFs or the ebook, and then also your videos. Once we master that, we start getting into the physiology, making sure that you understand what is normal menstrual cycle. And when it comes to females, obviously. And we'll talk about the hormones in terms of low dose and high dose estrogen, LH, and what does that do? And then ultimately, what does it mean when a lady then becomes pregnant, and what kind of hormones are you going to then be looking for? What happens to levels of progesterone? Who then comes to the rescue? For example, HCG, human chorionic gonadotropin. It peaks around 8 weeks, and then after that, it then pretty much dies off. Those are discussions that we're going to have in full extent. We'll continue discussion a little bit more. We'll talk about pregnancy. We'll talk about gestational diseases. So far, all that I brought to your attention thus far is abrupta placenta. Here, I talked to you a little bit about intra-amniotic infection. I further would then take you through placenta previa. I'd walk you through placenta creta and creta, and also then procreta, right? Placental issues. I wouldn't even just stop there. Then I would start talking to you about trophoblastic diseases, including how did it form cysts? That'd be a partial and or complete. You know what I'm getting at? I would then start talking to you about cancer, such as choriocarcinoma. This young pregnant lady here with that fetus, unbeknownst to either one of them, that such complications have taken place. Further discussion would warrant that we would get into our pharmacology. What does that mean? There's every possibility that this young lady may have hypertension. There'll be 3 forms of pregnancy in terms of hypertension that you'll be given either in clinic or on your boards. These include the fact that this young lady was an ACE inhibitor prior to becoming pregnant. You know that any one of those prodrugs must then be removed after she becomes pregnant because the ACE inhibitors will kill off the fetal kidneys. But she's still hypertensive. So how do you manage her hypertension in that pregnant lady? Well, then you start thinking about giving hydralazine, maybe give alpha-metodopa, maybe labetalol, maybe some nifedipine, right? Those do not cross the blood-placenta barrier. Those will not cause harm to the fetus. Or maybe there's preeclampsia, things that we haven't even touched upon, but things that we need to go into, no doubt, because everything that I do with you, and not just me, but all the associations that I have with wonderful people, such as Medical School Companion, such as Bacterial, to make sure that you have the best possible education from every single angle so that you can then go on to become the best possible doctor in a democratized fashion. That happens. Trust me. The world is going to be a better place. We'll be united as one. That's what I love about medicine. The fact that there are no boundaries. We all belong to the human race, and we all just want to be better people. All right. With that said, I bid you a wonderful, wonderful Sunday. Please be safe. God bless. And I will be seeing you very, very shortly.